All right, so like I said, there's absolutely no way I can talk to you about every single type of disaster, and that's because disaster can mean a lot of different things. So if any of you guys have done rotation with me, you know that New Jersey is my homeland. So an example of a disaster that happened probably about 5 miles from my house would be a weather disaster, Hurricane Sandy. Most of you guys think water, what's the big deal? But it really impacts the health environment when we experience disasters in our community. And the CDC actually estimated that there were more than 5,000 healthcare visits directly related to Hurricane Sandy that occurred in New Jersey alone. Remember, this occurred in the tri-state area, so that's just New Jersey, because that's all I care about, you know. Another example of a disaster could be a mass trauma event, such as the Boston Marathon bombing, where 3 people were dead on scene. However, more than 200 wounded individuals were taken to local emergency departments and really caused a surge effect and overloaded the capacity of those emergency departments there. And then something a little bit closer to home that could occur is a mass exposure. So in 2007, near Virginia Tech, there were dozens of folks that were sickened by carbon monoxide poisoning, which also caused impact to the local community and overwhelmed the healthcare system for that time. So what do all of these disasters have in common? If you look at the World Health Organization definition of disasters, a disaster is described as a serious disruption of the functioning of a community or society, which causes widespread damage or losses of some sort, and also exceeds the capacity of that community to cope with the event using resources that are readily available to us day to day. So basically, it's a catastrophe that we can't handle with our current resources, and it requires us to use a dedicated approach to the disaster event, and also can cause a lot of crisis in the community, so it's just overwhelming to all of us. The CDC has a great way of describing the various disaster categories, and I like their particular description because I think it highlights some of the areas that pharmacists can get involved. So many of the areas that occur with these disasters involve medication administration and medication management. So these are areas that we could be knowledgeable about and we could assist with. So guys, if you want to grab some handouts, I have a couple extra if you guys run out up here, so just let me know. All right, so what can we do? Who would be prepared if a horrible disaster occurred right now? Anybody? Probably not. So one thing that we can do to start out with is to understand the system that we have in place to manage disasters. That's the first step, is understanding what's going on and what's going on around you. The next step is who can we contact in the event of a disaster? What is the plan that we have for this disaster? What is my role? What is your role during a disaster? And then sticking to the plan and making sure that the plan is successful. So to do that, we need to understand what the standard approach is to disaster management in our country. So the National Incident Management System is an effort and a template to describe how we can respond to disasters across the country. And the purpose of this system is really to standardize the approach to disasters for every group that is involved so that they can successfully work together and so that they have expectations and an understanding of the staff members that will be responding, the approach that will be taken, and so there's accountability for everybody's actions and during the disaster event, because we don't have time for inefficiencies when there's a disaster situation. So the fact that everybody is operating from the same basic framework helps everyone because it reduces questions. So NIMS, as it's known, will provide this consistent template to allow every group responding to the disaster to operate in the same fashion. So this is government response, non-government response, private sector, and institutional response all can use the same template of response categories and definitions and terminology so that everybody understands each other. The incident command system is one of the parts of the NIMS that I wanted to highlight to you because it involves some terminology with particular staff members that you may hear during a disaster event. So the incident command system is a component of the national, the NIMS system. So what it offers is a management tool to respond to the disasters in a systematic way, and it describes the staff members who will be responsible for various areas of the response, including their goals during the response so that they can be accountable for what they're completing. So this is something that we can really steal and use for a lot of different situations. It doesn't have to be a surprise, chaotic disaster. It can also be utilized for a planned event. So events that we would expect there to be a reason to exceed our resources, we can initiate the ICS system, and that way we have everybody in place to respond to the disaster that would be needed. So a really good example would be a weather disaster. So we have the ability to predict huge storms. So in a storm situation, we have the ability to tell the institution how many people we're expecting to be required to maintain function of UVA, so care for our patients. It also provides everybody in place to handle anything that would happen. So say we have a really big snowstorm and we lose power. There are folks in place ready to go and to be deployed for that event in advance. This is an example of the ICS flow sheet of the staff members that would typically respond to any disaster. So I'm going to point out one particular position here that I want you guys to remember the terminology for, and that is the incident commander, or if it's a group of people, incident command. So the incident commander in this situation is going to be the person responsible for every part of the disaster event response. So they supervise the other areas. And they are ultimately responsible for planning everything, supervising all of the areas to make sure tasks get completed, and then they're accountable for ensuring that the response is successful. So they manage everything. There's other sections that are possible to be filled. Typically, we start out with what is known as FLOP. It low-key annoys me that it's not in order to make an acronym, but that's just me. But the operations section, planning section, logistics section, and the finance administration section are also main staff positions that can be filled here. These ones don't always necessarily get filled depending on the response, but those are going to be your main supervisor roles to ensure that all of the different tasks get completed. And this is a standard approach that you can see utilized across the country in a variety of different areas. So emergency management, emergency response, EMS crews use this, other institutions use this, our own institution uses this, government sector, non-government sector. So you'll see it everywhere. All right, so to keep these straight, NIMS is the overall framework or template of how we respond to disasters, and ICS is one of the standards that NIMS relies on, so they're interrelated. And ICS describes the roles of the staff members responding to these emergencies. All right, assessment question 1, and I expect involvement from the audience, so you guys better answer me. All right, which of the following is true about the standard approach to disaster management in the United States? Option A, the NIMS only applies to emergency response performed by the government. Option B, the incident commander establishes all of the incident objectives but is not responsible for managing staff activities and is not responsible for overall management of the incident. C, in order to be nationally prepared for any disaster, emergency management and incident response activities should be standardized and coordinated across all levels of government, non-government agencies, and the private sector. Or answer D, the NIMS and the incident command system are two completely unrelated and different approaches to disaster management in the United States. Yes, you guys are so smart. Okay, step 1 complete. You guys understand the standard approach. Easy, right? All right, next question. It's going to get more fun from here, I promise. That's the boring section. So now we're going to get into what we're actually doing. So how do we fit in a disaster response? So many of you might not wake up every day and question to yourself, how am I going to respond to disasters today? Maybe me, but I don't think you guys do. But lo and behold, you're a pharmacist, and you are one of the most accessible healthcare providers available to the general public. So any person who has a problem, they are very likely to be able to get to a pharmacist first before they're able to get to other healthcare practitioners. So you guys are very, very public and available, which makes our entire practice amazing. So we're also trained in the provision of care across all settings. So how many of you guys are interested in a specialty area? Who works on a team? Who works in a team that's a specialty area? Everyone. All right, so we have people in this room that can respond to a variety of different circumstances for a variety of different patient scenarios. That really fits into disaster management well because we can't predict disasters. We never know what we're going to be getting. So you guys are perfect for providing insight and knowledge about a variety of disasters. And of course, as I mentioned before, a lot of the categories of disasters specifically utilize medications in their management. So you are the experts of medications, and you are really highly able to help in these areas. All right, yeah, I'm talking. But what do our organizations think about our role? Well, the ASHP believes that we must assertively exercise our responsibilities in preparing for and responding to disasters. So we are capable of providing planning assistance and with initial disaster response. The APHA also supports our involvement in specifically bioterrorism and emerging infectious disease surveillance. So pandemic situations and outbreak situations, we're really highly qualified to assist in those areas. And even the NABP, who you wouldn't think would say much, provides statutory and regulatory language. So they basically are supporting laws being set into place that establish a role for us as pharmacists to participate in disaster management. So these are just three that I happen to pick, but all of the organizations for pharmacy support our activity and our involvement in disaster management. All right, so what roles can we perform? There was an article by the American Journal of Health System Pharmacists that gave a really good summary of the variety of roles that we can perform in disaster response. So as you can expect, clinical activities are one component. So ambulatory pharmacists can participate in clinics, in point of dispensing locations, in shelters, outreach programs during any sort of disaster in the community. Hospital pharmacists who have specialty interests can participate in management of the more sick patients that we'll see as a result of the disasters. Critical care pharmacists can offer emergency services and emergency response knowledge for these patients and assist with the acute crisis that's in place. And then they also address in this article other types of readiness. So these are areas that we don't typically think of as the acute responders for disasters, but they're really, really important. So there are specialty pharmacist positions that are involved specifically with preparing for weapons of mass destruction and pandemic outbreaks. Usually these are government working positions in the CDC and et cetera. Also, our IT pharmacists, the folks that are helping with our technology and with the facilitation of the clinical and technological world. This is really important to think of. I know that I personally have really appreciated having downtime procedures when, like we weren't able to get any sort of Pyxis to work in the ER for 6 hours. That was really helpful. So having a plan set in place for those types of disasters is really important, and these pharmacists are highly educated in helping. And then, of course, management. So, sorry, administrative residents, you didn't get away from this presentation, but it's very important to know how to lead a department in times of disaster. This is a high-stress environment, and having plans in place to keep everyone calm and focused on their job is really important. So, all of these roles can work together to make pharmacists very, very reliable in management of disasters. All right, so this is a more fun question, like I said. Which of the following roles can pharmacists perform before or during a disaster response? Option A, providing mass antibiotic prophylaxis at a point of dispensing location set up in the community after a biologic exposure. Option B, developing restrictions to use or identifying alternative products to weather a drug shortage affecting medications commonly used during cardiac arrest response, aka our entire last year. Assisting patients to request refill authorizations for meds for chronic conditions needed in advance of an expected natural disaster, option C, or option D, ensuring that medications are available and frequently restocked in an emergency department experiencing a patient surge or a mass casualty incident. Or E, all of the above. E, we could do all of these things. So that's a big impact for these patients that are experiencing disaster. Good job. You guys have 100% so far, so keep it up. All right, so identifying appropriate disaster resources is the next part that we're going to discuss. I'm going to mainly focus on one particular resource, which I know is riveting and you guys are so excited for. But unfortunately, the first thing I have to remind you guys of is yourself. Personal preparedness is the very, very first step in emergency preparedness and disaster response. You are responsible for your own knowledge, and you are responsible for knowing what to do in a situation should it take place. So knowing the resources that you have available to you really helps during those crisis moments when you're flustered and all of the stuff is going on. Knowing where to go and where to look for things is really helpful. So take the initiative and be prepared personally for events that occur by just knowing your system and making sure that if you ask questions, you ask them before the bad stuff happens. And that's important because there is expected resource expansion during disasters, but unfortunately resource expansion takes time. So there is an expectation that you're going to be having to manage the disaster initially on your own before your resources come in to help you. So typically there is a stepwise approach to resource expansion generally with disaster management. So first we're going to use yourself. So can you manage it on your own? Then you're going to recruit the efforts of colleagues and perhaps the institution, so like the help chain, for example. And then you're going to start recruiting assistance from the local community. So these are your volunteer agencies and community initiatives. And then from there, we could ask for state assistance, which is going to take some time to go into place. So Health Department, National Guard, they don't appear right away. And then the component or expansion that takes the longest to show up is typically national because they're coming from a long distance. They have to like recruit supplies and get to you. So FEMA and CDC would be options, just examples of those, but that typically takes a while. So most emergency preparedness recommendations are to ensure that you personally are prepared for any issue for at least 72 hours because that's how long it could potentially take for help to come. So that's I just wanted to like blow your minds with that knowledge so you could just be aware of that as it may apply to you. All right, so now we're going to be focusing in, because again, this is probably the most scary thing that you'd have to deal with the ChemPack. So this is when you are the disaster resource. There is not enough time with ChemPack response for you to wait for assistance from another party. So you are going to have to be prepared to assist with this initiative and to understand what's going on. So we're going to go through it really in detail. I am going to ask for a volunteer. So if you guys have an urgent need to come up and be on camera, please do. You can just kind of think about it. Don't all come up at once. But we're going to go through this really thoroughly and make sure everyone understands what the ChemPack is and how to use it, when we would use it, everything. All right. So I'm sure you're saying, like, I've never used a ChemPack. Does anyone even know what a ChemPack is? Who doesn't know what it is? Who has no idea what I'm talking about right now? Okay. Yeah, it's okay, because you're going to know by the end. So if you don't know what I'm talking about, this presentation is for you. All right. It's okay. So I think a lot of our department had this general response a year ago. I can recall multiple people asking me what ChemPack is, so it's fine. Don't feel sad. So does this even happen? Do we even utilize the ChemPack? I don't understand why this person's standing up here making a big deal out of it. Well, yes. So the ChemPack is utilized for organophosphate poisoning. Does anyone know what an organophosphate is, you chemistry nerds? Okay, I'll remind you, don't worry. So organophosphate poisoning is something that you probably haven't heard of. So I want you guys to take a guess at when the last time an organophosphate agent made the news. I think that Katie knows like where I'm getting it, but so a couple months ago, so this is the scariest situation that you could possibly imagine an organophosphate making the news for. So this was a chemical attack that occurred in another country, so nothing in Charlottesville. But these agents are available and they do make the news, and we have to be prepared for the worst case scenario. The other problem with organophosphate agents is that nerve agents are like the scary Jack Bauer 24 kind of thing that we talk about, but organophosphate poisoning is very common in terms of accidental exposures and poisonings. And the reason for that is organophosphates make up the most common type of pesticides that are used worldwide. Surprising to anyone? So the World Health Organization, and this is a little bit older in terms of data, so it's probably like a decade or so old, but the estimate at that time, at the last time that they did this, was that 3 million people annually are poisoned by organophosphates worldwide. So 250,000 people are killed by organophosphate poisoning worldwide. This is particularly problematic in countries that don't have great parameters for use or safety initiatives to educate the public on how to use organophosphates safely and properly with protection. But with farm being all around us, organophosphates are regularly used to grow crops and to allow pesticides to prevent crops from being eaten by bugs. So this is something that we have exposure to with the public that could potentially cause a problem. So not just with terrorist-related attacks, but with accidental mass exposures related to farming industry. So this is something that it does happen. There was actually a report probably a decade or so ago that in these developing countries, the most common cause of death from an exposure or an overdose was organophosphates. With the terrorism component, the thing that makes it scary is that they are so readily available. So anyone can go pick up some pesticides and use it for a malicious purpose. So we will talk a little bit about the terrorism concern, but just keep in mind that this happens without terrorism being related to it. So just something to think about. All right. So what is an organophosphate? So obviously phos, right? So that's important in its mechanism, and we'll talk a little bit further about that. You have classes that can be described in terms of the pesticide forms and the nerve agent forms. The pesticide forms are usually divided, depending on the literature that you're looking at, into diethyl pesticides and dimethyl pesticides. So the diethyl pesticides, it's just simply based on the molecular structure. Parathion is one example of one. And dimethyl pesticides, an example would be malathion. Typically with the dimethyl pesticides, the actual molecule goes through a process called aging relatively quickly. And what that means is when it elicits its effect, it morphs the molecule into like a permanent, irreversible molecular structure. So you have this increased toxicity because it's more difficult to combat that chemical change. So dimethyl is typically more toxic, and it's more quick to cause problems. So the malathion is typically the worst of the two options for pesticide exposure. For the nerve agents, these were man-developed. There's the G series that was developed way, way, way long ago before World War II, and this will come back into play when we talk about some of the data supporting use, because it was before we did evidence-based medicine. And then the V series is, the best example of that is VX gas or liquid. So does anyone know what V stands for? So it stands for venomous. And that's because the V series are much more toxic. So they're about 10 times as toxic as the G series agents. So they were literally designed for chemical warfare. So worst case scenario. G series typically just forms gas, which means it dissipates quickly. The V series can actually be liquid or gas, which means you can have mass exposure that stays on the skin and continues to be absorbed in illicit effect, in addition to being much more toxic because of the aging. All right, so who needs a reminder on acetylcholine? Good job. Okay, so acetylcholine is a neurotransmitter. And we're going to go through the normal happy life of acetylcholine a little bit, and then we're going to talk about what happens when your body gets exposed to organophosphates. So acetylcholine neurotransmitter is responsible for activating nerve impulses that activate our muscles, so smooth and skeletal muscle movement, and also activating our autonomic nervous system. So there are receptors, cholinergic receptors throughout our body from head to toe that allow acetylcholine to activate and allow our body to perform normal functions. In order to keep the status quo, there's a product called acetylcholinesterase, which stops the activation of acetylcholine by grabbing onto acetylcholine, ripping it in half, and making it inert. So it breaks it down. It's an esterase. Good chemistry reminder. So what happens when we add an organophosphate to the mix? So organophosphates are going to phosphorylate, right, phos, the acetylcholinesterase. So the acetylcholinesterase can no longer grab the acetylcholine out of that synapse. What ultimately happens is the acetylcholine ramps up and builds up and fills up all of the receptors that usually would be binded to it. And there's no way of it going away, so it just keeps accumulating and accumulating. So two types of cholinergic receptors include your nicotinic receptors and your muscarinic receptors. And the acetylcholine that's built up is going to activate both of these, and it's going to cause this massive overstimulation of the receptors. And guess what that leads to? Toxicity. And guess what type of toxicity? I hear people whispering it, so someone just shout it out. Sludge! All right. So you get this cholinergic crisis. There's actually 3 phases of the toxicity. The first one is the sludge, right, the cholinergic crisis, which happens minutes to hours from exposure. So remember, these are liquids and gas. They get stuck on people's skin. They can be ingested. They can be inhaled. And then immediately they're going to be absorbed and elicit an effect. It's bad. After the cholinergic crisis occurs, you have this second phase called an intermediate syndrome, which primarily affects respiratory function, which means your patient can crump hours later. Sorry, critical care pharmacists, that's what's going to happen once they get up to the ICU. And then weeks after exposure, which is not so much related to the cholinergic response, but related to some other receptor activations, which we won't talk about here, there's this delayed polyneuropathy weeks and weeks after the exposure. Obviously, I'm talking to you about something that you need to treat immediately, so we're going to focus on the cholinergic crisis because that's what usually kills our patients. All right, so what is so bad about our cholinergic crisis? You heard some sludge shouted out. So no, it's not like actual sludge. Sludge stands for the cholinergic response when the receptors are activated. So you have salivation, lacrimation, urination, defecation, and then a bunch of other stuff. Some of that other stuff is bad, which includes respiratory depression, bronchospasm, and seizures, which is pretty life-threatening if you ask me. But why is this so bad? So think of where all of these cholinergic receptors are. Everywhere. So this affects the patient from head to toe and causes this massive body response. And it's really, really difficult to have a normal body function when all of the liquid that could possibly be created is being released and you are having a seizure. So it's very, very dangerous for these patients. All right, let's treat it. Who's ready to treat it? Woohoo! All right, just trying to get you guys excited. I'm gonna remember this when I decide on who comes up and hangs out with me for a few minutes. All right, so first thing that we can do to treat is simple, decontaminate. So again, these are gonna be products that stick to your skin and your clothes and can be ingested, inhaled. So one approach is to rip off those contaminated clothes, rinse the patient off, and prevent the dose toxicity related to the organophosphate. This is highly dose related. So the more exposure you have, the more receptor activation you're gonna get. So decontaminating is definitely helpful. All right, but I'm saying that, but how many of you guys think that there's evidence to support that? There's actually not. So it's unethical to do a study where you like spray someone with organophosphates and then decide like, you time them, I guess, to see how long it takes for them to be in a cholinergic crisis. If you take their clothes off first, that's not nice, not something we generally do. So this isn't evidence supported, but it's a pretty good idea, so we do it. Supportive care. How many of you guys have BLS certification? All right, you're my people for supportive care, ABCs. And then, of course, there's antidote administration that we can do. So this is what we're going to go in depth and get you guys comfortable with the mechanisms and the doses here. So two referenced antidotes for this treatment is atropine and oxyms. And then, of course, additional toxicity can be managed with our friend diazepam. We're pharmacists here. We all know what a benzo is. I won't focus on that as much. All right, atropine. Atropine is the mainstay of treatment for these patients. So what atropine does is it's going to take the acetylcholine and it's going to kick it out of the muscarinic receptors, and it's going to block the acetylcholine from activating those receptors. So technically, when people say antidote, they're not using proper terminology. Derek and I were having like the ironic conversation with Alanis Morissette, and wasn't really used properly. Same idea here. So it's not technically an antidote. It's not doing jack to the organophosphate. But what it is doing is it's preventing the acetylcholine from working. So notice I said muscarinic receptors only. Atropine is not effective for any of the nicotinic receptor response. However, the effect that it has on the muscarinic receptors is profound, and it's good enough to stop the cholinergic crisis. Again, with the majority of these agents being developed prior to World War II, we have no idea what the ideal dose is. Hate to break it to you. So if you say that you don't know what it is, that's technically true. We generally recommend use of 0.6 to 6 milligrams IM boluses for atropine for these patients, and that can be repeated every 5 to 10 minutes based on response. All right, does that sound weird to anyone? All right, so what is our usual atropine dose for a bradycardic patient? Who's alive? Anyone remember? 0.5, right? So these patients are getting a lot more than that, even in one single dose, and then those doses could be repeated every 5 minutes. And it's not like there's a dose cap here. There's not. You literally just give it every 5 to 10 minutes until the patient stops secreting things and can breathe again. So there's not really a dose cap, which means the amount of, are there any technicians in the room? No? Okay. Anyone who does operations who knows how much atropine we have stocked in the ER? How many patients do you think we're going to be able to treat with the ER atropine that we have? Especially, I'm sure there's a shortage of it. I don't even know, but not a lot, right? So we are going to go through all of the atropine that we have pretty quickly. There are, in our chem pack, which we're going to discuss, some specific injector supplies of atropine that we're going to have you guys look at. But this is a lot of atropine for these patients. Pediatrics, who's a peds pharmacist? All right, so there's no evidence really to say any dosing for peds. Typically, most of the recommendations are anyone who's greater than 1 because of the amount of atropine that they're going to require. You just give adult doses and hope for the best. You can potentially, if you use like a very hard to find CDC resource, use like weight-based dosing for peds, which is pretty close to what you'd use for like just general atropine administration, 0.05 to 0.1. But usually you're going to be maxing out at 2 to 6 milligrams for these patients. So again, no real great dosing options. We just kind of use what we think works. Monitoring here, this is going to be the important part because that's how you're dosing it. You're dosing based on symptom resolution and avoidance of atropine toxicity. So you make sure the patient isn't bradycardic or developing a paradoxical arrhythmia. You make sure that they're not hyperthermic, and you observe whether or not the sludge effects are resolving. And that's when you know when to stop. The reason that we don't really know much, again, is because there's really no RCTs, because this is the general consensus is that atropine is the treatment for these patients. It's unethical to compare to placebo. There are some comparisons to glycopyrrolate, which seems like they're equivalent, non-inferior to each other. But atropine is still the gold standard. All right. The next one are the oxyms. So I'm going to specifically discuss pralidoxim here because that's what you're going to see in our chem pack, and that's going to be the most commonly used agent. So where atropine blocks your acetylcholine from activating muscarinic receptors, pralidoxim has a different effect. So pralidoxim is going to be known as a cholinesterase reactivator. So what it's going to do is it's going to go to that phosphoryl moiety that the organophosphate added to the esterase, and it's going to kick it out and allow the esterase to be reactivated so that it can happily chew up acetylcholine. So it's going to get rid of the acetylcholine by breaking it apart. Again, we have no idea what the most ideal dose is here. There's no real RCT data. We don't really think that this works as well as atropine. The case reports that are available are very contradictory, and you can really form no great conclusions from them. However, typically pralidoxim is still used early on in the management. And the reason that it's used early is because of the aging effect that I mentioned earlier. So again, these substances work by breaking the molecule apart and kicking off that phosphoryl moiety. If the organophosphate has already aged and has already formed, has already continued the molecular direction and made the molecule resistant to kicking off the phosphoryl moiety, then it's not going to work. So it's recommended that this product is used very, very early in the treatment or not at all. So we generally recommend no more than 3 doses, and the timing in between doses is usually a little bit greater, so 30 to 60 minutes apart. You could, if you were using auto-injectors, still do the every 10 minutes initially, but there's no really utility using it after the first couple of hours of exposure. So dosing is all over the place. General supplies are 600 milligrams for adult dosing. There are weight-based recommendations for pediatric dosing with a max of adult dosing. And toxicities here would be tachyarrhythmias and hypertension. So there are some case reports that suggest that the tachyarrhythmias and hypertension you'll see with use of this product exceed placebo, but they're very small scale studies. All right. Diazepam, we'll go through this really quick. Management of the seizures as a result of the sludge effect. So it's not actually doing anything as an antidote. It's just going to stop the patient from seizing so that you can stabilize the patient. So really any benzo can be utilized here, but the diazepam is the most used in this indication. It's going to be what is stocked in our chem pack, so it's important to just understand the dosing. Again, with the rush to treat the patient and not waste time getting IV access as the other agents, the recommendations are for IM administration, which is kind of weird. We don't really do that a lot, especially in peds. So just to go over that, adult dosing, 10 milligrams, peds, it's weight-based, but you can really do 5 or 10 depending on how big they are. 5 years is usually the general cutoff, but there's no specific recommendation. Also, benzos can be used for seizures appropriately for other agents. So if you run out of diazepam, don't sweat it. You can use any benzo. All right, so to remind everyone, the antidote treatment for organophosphate toxicity. So here is our overwhelmed nicotinic and muscarinic receptors overwhelmed with acetylcholine. And the atropine is going to just kick out the acetylcholine from those receptors specific to the muscarinic ones and stop the process and stop the activation and overstimulation there. And then you have your pralidoxime, which is going to kind of change the molecular structure of the acetylcholinesterase and allow it to chew up acetylcholine there. So you're going to reduce the acetylcholine presence in the synapse. All right, decontamination. I just wanted to show you a quick picture here of what that looks like. Funny story, we had a decon exercise and I encouraged my pharmacy student to participate as a patient, so they were able to go through the whole process. But we actually have a decon tent that we can have set up in 11th Street Garage here at UVA, so that way we could decon patients outside of the emergency room to reduce the impact on the healthcare workers taking care of them. So any decon should be done in the field or outside of the ED. All right, now we're going to talk about where the chem pack is. So that is not the response, I don't know. So when you get asked where and what the chem pack is, that's not the response you want to have. We want to know how to treat these patients as quickly as possible because all of those horrid cholinergic effects are going to be happening within minutes of exposure for these guys. So there are two different kind of subsets of supplies that are supplied by our federal government for emergencies. One of which is the ChemPack program. It's an initiative of the CDC. It's part of the Strategic National Stockpile, and it provides antidotes specifically to these nerve agents that we just discussed. They're pre-positioned in different regions throughout the country for quick access to these types of emergencies. And then we have the Strategic National Stockpile overall, which is just an additional backup supply of all kinds of other stuff. So it has like antibiotics, it has antitoxins, like botulism and all these biologic exposures. And the Strategic National Stockpile is also located throughout the country, but with the expectation that it would arrive to a site within 12 hours. So if you get a call that's frantic from an ER attending downstairs and they say, we have a exposure, there's 20 patients here now, you need to go to the ChemPack because that's what we have on site at our hospital. Strategic National Stockpile, 12 hours from now, is not going to help. So some ChemPack facts. There are, because this is run by the CDC, there are specific folks that are dedicated to have permission to request ChemPack activation. So this includes the ED attending or the ED charge nurse on behalf of the ED attending, anyone in hospital administration, or a designated local ChemPack cache custodian. So there's designated folks that are allowed to request opening the ChemPack. From your perspective, for working your clinical shifts, typically you would get the call from either ED attending, ED charge nurse, or a hospital administrator or like a supervisor. The purpose, again, is only for organophosphate exposure. And the expectation is that hospitals aren't going to use it for no reason. They're going to attempt to use their supply first. Notification occurs automatically when ChemPack is opened. So there's a line that's directly connected to the CDC. So the second you unlock it and open it, they get notified. There's also an expectation that the Virginia Department of Health will be notified within a reasonable amount of time, just so that they can prepare for any public health crisis from a state perspective. All right, where is the ChemPack located? So say you get a call and someone says, I need the ChemPack opened right now. Where are you going to go?
Back left-hand corner of the slide.
Excellent. Great job. Gold star for you. So this is a picture of it in all its glory. It's literally just a cage full of drugs. Sorry. Sorry if you were expecting anything more. It is located in the back left-hand corner of the slab, hopefully not covered by other stuff, but it is there. All right, what about the ChemPack key? How are you going to open it? It's locked. So you could ask the supervisor, but what if an ED attending asked you personally to open it and they have appropriate permission to do so? They need it like now, yesterday, usually, when it's an ED attending. Anyone? So Pyxis, and this is a new development for some of you folks. So in the past year, we relocated the ChemPack key from the supervisor office to be in Pyxis. And the reason is that sometimes the supervisor's office is locked, and that's probably not ideal for a 24-hour expectation for quick response. So if you go to the main pharmacy Pyxis and you sign in, and you can search either key or ChemPack, and the key will open for you, and there will be one there. So you have access quickly to get to the key if needed. Contents include auto injectors and also some vials that can be reconstituted or drawn up for patient-specific dosing, which is really helpful for pediatric or elderly patients. So most of the ChemPacks that are distributed nationally are either one way or another, where they're almost entirely auto-injectors or entirely draw-ups. But because we service such a broad variety in our region, and we also supply the ChemPack to potentially EMS crews who are traveling to a site, we have about a 50-50 distribution in our ChemPack. So both types of products are going to be located there. The other thing that will be located inside the ChemPack is a bunch of diazepam. So that's important to know as well, because diazepam is a controlled substance. So when ChemPack activation occurs and you need to bring any of the innards of the ChemPack somewhere, you need to maintain chain of custody because there is a controlled substance inside of it. And there's some paperwork on the front in case you need to do so or have anyone sign stuff. And this is just for your reference. So we have national chemical stockpiles that used to be distributed more broadly. The only 2 states as listed that still have chemical stockpiles, one of which is quite close to us, so Kentucky. So just so you guys are aware, we do have a pretty close vicinity to a large chemical stockpile for the United States. All right, now it's time for you guys to earn an extra gold star. Michelle, I'm sorry, you've already earned one, so you've exceeded your capacity for the presentation. So I need a volunteer, and I'm probably going to ask Matt to do it if no one else volunteers. He's just getting up. All right, so you guys all got handouts, hopefully. Who needs one still? Anyone? All right. All right, so quickly, Matt is going to help me demonstrate how to use a Mark I auto-injector. I have a diazepam one too, if you guys want to play with it. I'll pass it around so you can see it, as long as you promise to give it back. Okay, so if you look at your sheet, oh yeah, here, there's one left. Well, actually, I might, you can have it in a second. Here, wait, there's 2, that's the 2-sided one. You can have them. Yeah. All right, so the instructions to use them are literally on them. So just in case you lose your paper, that's okay. There's instructions on them. It's very, very similar to EpiPen administration. So this is what it looks like for those of you who aren't looking at it personally. I'm going to pass it around. But so it contains atropine and pralidoxim. And the intent is, you guys can still hear me, the intent is to take it apart, one first, then the other, and you can inject them both to treat yourself, or you can treat someone else. So back to our discussion, we have atropine here and pralidoxim, so which one do you think that we should inject first, because it's the one that actually works for this disease state? Atropine, so atropine always goes first, because it's the gold standard. All right, so it's just like an EpiPen. You can either put it in the lateral thigh, or if someone has really skinny, scrawny legs, which I think, Matt, you're good, you can do it in your back chub, in your haunch. So you can go ahead and inject yourself. Really? Yeah. It's not a real needle.
I sign a waiver?
No, it's not a real needle. All right, so hold for 10 seconds. And then vertically remove it. And I mean, if you really want to, you can do a little bit of like leg massage, but I'm sure that in a scenario in which you're vomiting and lacrimating and salivating, you're probably not going to have time to do that. And then immediately after the atropine, you do your pralidoxim. 10 seconds, then remove it, and then you're good. So I'm going to start passing this around. There is like a little thing that you could reset it with, but it kind of takes a little bit of time. So I'm just going to pass it around so you guys can look at the directions. And make sure you give it back or I will find you all. And then another option for an auto-injector that's located in our chem pack is good old diazepam. So this also is not real diazepam, I promise, Matt Jenkins. I'm not like not going to inject him with diazepam. Yeah. So do you think that Matt's going to be able to give himself diazepam if he's actively seizing? You can feel free to act at any point. Right? Okay. No, so this is meant for someone else to give to a patient who is actively seizing only. We're not going to like give someone 10 milligrams of diazepam if they don't need it. That probably wouldn't be ideal. Same exact way. So we're going to pull off the safety cap, stick it in your thigh, inject, hold for 10 seconds. He's benzo naive, so he's going to be out for a little bit. And then we're done. So that's how we would be able to administer that. And then when these are used up, because typically we're going to like allocate these to EMS folks going to the actual site of the exposure, and for adult patients. Once these are used up, we have a ton of draw up your own, but that requires you guys to do math, right? So these are the easy ones. Here, you go take that on your side so that everyone can see it. Okay, so you guys can all take a look at those. Just a reminder of where you inject your thighs or your muffin top, I guess. I'm not really sure what you would formally call that. All right, any questions about that? Muffin top or thighs? Done. Yeah, love handles. I'm just hungry, so I like calling it a muffin top. Okay, so strategic national stockpile, this is more for your reference because this is not going to help you in the moment. So this is going to be 12 hours later. So just be aware of that. It includes lots of extra goodies, so antibiotics and antivenins. And these are just a list of the contents for your reference. Unfortunately, the one kind of unique thing about the strategic national stockpile is that I can't tell you where it's located. All I can promise you is that if I trust my government, it is located within 12 hours of us. So the locations of the SNS are actually not publicly released so that we can protect our supply if needed. All right, assessment question 3. Which of the following is true regarding a disaster resource located in the inpatient pharmacy? A, Chempac is located in the back of the slab and intended for use during acute organophosphate exposures. B, Chempac is located in the back of the inpatient pharmacy slab and is intended for use during exposures to biologic agents such as anthrax. C, there is a strategic national stockpile located right in our inpatient pharmacy and we can use it immediately for acute exposures. Or D, Chempac does not contain any controlled substances, so if we get called for it, we can just roll it right up to the ED and just leave it out. Anyone? A, good job. Still at 100%. Keep it strong for the end, guys. We're almost there. All right. So I am going to very quickly discuss some future directions for the inpatient pharmacy disaster plan. So like I said, we can't predict all disasters. I tried to give you kind of a little taste of disasters to get you excited about it and get you aware and active for Chempac activation if ever needed. But we have some future directions for integrating us into the current emergency management approach here at UVA. So this is just the proposal. Hopefully this will be going live in the next month or so. Currently, we have our hospital administrator serving as our incident commander, so really modeling the structure of the strategic approach for the United States. Also coordinating with the director of emergency services. We have the ED attending and the charge nurse and the ED manager on duty working closely in the emergency department for care there. And then the goal is to have pharmacists integrated into that communication structure so that if needs are identified for medications or any sort of Chempac activation, the pharmacist would integrate and communicate there, and then utilize our supervisor and our help chain to help make the whole department aware. We have made some progress with incorporating our administrator on call into our MCI pager response. So we are getting departmental notification for any sort of emergent MCI event or surge event, which is a great step in the right direction. And the next step is going to be making sure everyone is comfortable with the management of these situations so that we're prepared as a department. All right, you personally, if you guys want to get more involved, there are a variety of approaches that range from institutional involvement to national involvement. One that I will draw attention to is www.train.org. They offer, some of them are a little bit dry, but they do offer some courses on disaster planning and emergency management topics, and some of them are very interesting. You might find with your particular practice areas, there's some psychiatric disaster management that may incorporate to more clinic approaches. There's a lot of good courses there that can help you maintain comfort in these areas. All right, final question. Did everyone get a chance to look at the kit? Where's it at? You guys still taking a peek at it? So true or false? You understand how to administer a Mark I auto-injector? True. Did anyone say false? Okay, good. I was going to say, if you said false, we were going to have you come up here and practice the whole thing again, but okay. All right. So I hope that gave you a little taste of disaster response, and I hope that you guys are more comfortable with Chempac topics. If you guys have any other particular questions about disaster management, I'm open. So, Hey.
Hi. There might be some ethical boundaries to an answer to this question, but I was wondering if there's a reason atropine is used rather than azidiamine or scopolamine, and whether or not, say, the fix is broken, you can't get the key, you should just like shove Donatol and put some key patches all over the key.
That's a great question. So his question was, why do we choose to use atropine for this indication and not another product that would elicit a similar effect? The answer to that is honestly back to the consensus of what was always used. So although, like I said, we have very little randomized control trial data supporting the use of atropine, but the data that we do have is based on case reports and based on military operation data, and it all is involving atropine. So you certainly could consider using an alternative. There are, like I said, some comparative studies looking at glycopyrrolate versus atropine due to shortage situations, but the one that we know the best is atropine. So you could certainly apply your pharmacokinetic knowledge if we run out of atropine and need something, but it's just not well documented in literature. So it's just what we've consensed to do. Yes?
You had mentioned the use of the route for atropine being IM. If the patient has IV access, is that an acceptable?
That's a great question. So Derek asked if most of the data that is available for ChemPack utilization is with the IM route. So he was asking if we had IV access, if that would be acceptable for use. So absolutely, yes, it would be acceptable. I personally would probably cut my total dose administered per dose at 4 milligrams rather than 6, just to prevent over-atropinization of the patient. But you can certainly use IV access if it's there. Typically, though, the recommendation is to not waste time to get IV access, so that's why everything is promoted as IM. But you'd use the same doses, and you could just give them IV. Any other questions? Yes? He's recovered from his diazepam injection.
So, say there's a mass organophosphate poisoning like 10 miles from here, and they're having problems transporting everybody to the hospital. Would we ever be asked to load everything up into a car and take it to them?
Yes.
Would the response be no, we have to?
No. We would want to get this product. So again, we are the regional site, which means the patients aren't always going to come to us first. So there are scenarios, especially with farmland with limited road access, where it may be faster for us to transport the ChemPack to the site, which is acceptable. We just have to make sure we're using the proper forms, which are located in front of the ChemPack for chain of custody. So it would be appropriate to deliver that to the site. It probably would be faster for the patient as well, because if you think sending an ambulance out and then having them come back, that's double the time. So that may be a possibility as well, which is why our ChemPack has products for EMS administration.
And as far as dispensing the diazepam, do we as a pharmacist have to keep record of every patient that received it? Or if it's a mass incident, do we just start tossing it out?
So the records have to be for taking the diazepam from our department to the site, and then there's paperwork that you would fill out for administration after that, similar to what we would do for the narcotic agents that we give out in our rescue squad boxes. So there would be a period afterwards where we would make everything kosher.
I'll tell you, Matt, honestly, do the best you can and document what is
Yeah.
the best interest of the patient, but take care of the patient. Don't worry too much about the paperwork. The worst thing is, you'll have the CDC on your side, the DEA against you. So,
Yeah, and there is, like I said, there is paperwork on the ChemPack. If you go back to the picture, if I can get to it. So there is a folder with some paperwork that addresses the transportation of the products. It's very, very limited. It's nothing near what you would see with our DEA forms, but the main thing would be just to maintain a basic chain of custody and to get the drugs to the patient if needed. Because that's what this is for. So.
After it's over, are we responsible for bringing it, whatever's left over back, or reconciling it, or will officials be here to take care of that?
typically there would be officials in place because the CDC gets notified right away. And then we also have like a specific ChemPack agent that is on staff here that would assist with communication with the CDC regarding all of the reconciliation. So it would be taking care of the patient first and then worrying about that stuff afterwards. And they would also use that reconciliation to determine if additional products are needed to be sent to us. That's another great question. So sorry, everyone was just asking, I didn't restate the question. For those who can't hear, what would happen if there were an event that required the ChemPack to be sent to a location, and how we would reconcile those papers.
So I assume this isn't on wheels, so we would break the chem pack and have some kind of cart or whatever rolled up.
Mm-hmm. Yeah, so you could, typically if you're going to get activation, they usually, they kind of have to know how many patients they're expecting, so you could use your discretion, but you'd break it open and then you could transport the boxes within it. So each box is marked with what it contains, and it's by drug. So there's like a box of atropine auto-injectors, a box of X. So you would go based on what they would require. Correct. So Bruce asked about CDC responsibility with out-of-date products. So the CDC does do a certain number of checks per year, which I think they're modifying the procedure for. I think it's currently 2, but they're looking at, I think, making it less frequent. And there also is data that the CDC regularly releases to expand expiration dates. So in the events of drug shortages, because some of these products have gone on and off of shortage. So they're frequently updating that as well. So some of them may look expired, but actually be approved for use for beyond dating that the CDC manages. So they do all of that.
So Donna, would it be safe to say if it's in the chem bag, it's safe?
It's safe to use, yes. It's been checked. And there's actually, I believe, a date, I think right on it, of when it was last reviewed. Yes, yeah. Yep. Yeah, so Michelle was just reiterating there is like a date written right on with all the paperwork of when it was last checked and the expiration date approval. Yes. Mm-hmm. Sorry, did I miss a question? I thought I saw a hand. Go ahead.
So you said there's an alarm once that's open. So if that was open, what would be like their point of contact? You said there's organizations that would respond.
Yes. So when it's connected to, the only way I can describe it would be like a phone line. Yeah. So right there. Can you see that? So when it's opened, it'll automatically call a phone in the CDC, and their representative will be aware that it was opened, and then seek out to contact our custodian. So they will try to reach out to us to evaluate what's going on. So it's pretty instantaneous that they find out. The group that typically has a little bit of a delay with notification is the State Department of Health, just because we have to contact them, and usually we take care of patients before we do that, or it's kind of happening at the same time. Any other questions? Yes.
In regards to distribution of the ChemPack, at what point would us as pharmacists have a say in regards to, say there's multiple regions that are covered by UVA? Would it just be up to the incident commander, or would we have a say and say that there's about this many people, you would require this many of X, Y, and Z?
So let me make sure I'm answering your question correctly. So I think your question is if there's multiple incidents, who would be responsible for distributing X amount to each incident? That would usually fall within the incident commander, and that would be requested by the permitted requesters at the time of the request. So we could certainly assist if they have questions of what we would need to delegate, but that's usually already been decided by the incident commander. So they would be doing the planning of all of that. So they're responsible for the whole response. So it's usually an administrator level person, whoever's on call. Any other questions? Are you guys ChemPack experts now? All right, I think you are. I feel confident in you. All right, well, I really appreciate you guys coming and for all of your attention during this wonderful discussion that we had.